Hope you can see that.
Well, gentlemen, good evening, and thank you for the opportunity to present this persona uni. And I was so impressed with everything that Adarsh and Gurva mentioned and their technology perspective that I too decided to move into the robotic zone. The only thing is I use the cerebral robot. So this is the history of this patient, 58-year-old male medical practitioner with a history of progressive pain in the left knee. X-ray revealed needle compartment with minimal changes in the patellofemoral. It is a correctable deformity. So pretty much we followed the ideal indications and negative serology for inflammatory disease. So this is a video, and I'll just let it run. Be happy to answer any questions that you may want to at the end.
हाँ किया ना दिखता ना मैं हेलो क्या है
Sir, there is no audio in this video, sir.
Dr. Rajgopal, no audio for this video of yours?
Can't you hear it?
No, we can't, sir.
No, sir.
Oh, okay, because it's on the commentary.
Sir,
Well,
stop share, sir.
I will give a. It's already recorded, so I'll speak over the.
Sure, sir.
So this is a medial uni compartment for a degenerative arthritis and a correctable deformity. We use a medial curved parapatellar incision about 2.5 to 3 inches. In this case, we've used a slightly longer incision just for ease of recording. And we take the proximal end of the incision up to the base of the vastus medialis. And this allows us to subluxate the patella. The uni on the persona platform is basically intended for the medial compartment only for the moment, and the exposure is aided by excising the infrapatellar fat pad, and we need to identify the medial third of the tibial tubercle, because that, as you'll see shortly, is a critical landmark for us to be able to orient our tibial cutting jig. So this is fundamentally a technique where we do the tibia first. We release the anterior attachment of the medial capsule, and we go just up to about 1 centimeter. Again, differentiating from a total knee where we go, certainly I go all the way to the back of the knee and a varus knee. You want to make sure that you do a very limited medial release. You do not want to over release. At this point of time, you resect and clear the proximal tibia. One of the very interesting points in terms of the instrumentation of this procedure is a method whereby we actually protect the tibial from the sagittal cut, because one of the complications that we've seen a lot of is extension of the sagittal cut and a fatigue fracture or failure of the tibia and collapse of the medial component. So what we really do is we identify the medial border of the medial plateau, and this is really a very important step in the surgery. So we go along the lateral edge of the medial condyle of the tibia, and we make a mark with the cautery. So this actually helps us to orient, and that's what we're doing over here. So this cautery marks the medialmost part of the intercondylar notch, or the lateralmost part of the medial tibial plateau. And this is the line that we are actually going to orient our lateral edge of the tibial cut. So the tibial cutting jig is site specific, and this basically has the option of being able to be moved up and down up until the very last step. So first of all, we align the cutting jig to the intercondylar notch, and you can see right medial to this fixation pin is a slot which actually allows us to orient a screw. And this is important because this will limit the depth of the sagittal cut and thereby protect it. And the other point, of course, is the fact that with most of us who do manual surgery, one of the challenges with the unicompartment is removing too little of the tibial bone. So you want to take away about 4.5 to 5 millimeters of bone that give us a reasonable amount of polyethylene, because it starts at 8 in terms of the total height. So that gives you about 3.5 millimeters of actual polyethylene. And you can see over here that we are now oriented both in the longitudinal axis and in terms of the slope. The idea is to reproduce the natural slope of the proximal tibia. And this is again a very critical part. And this is the pin that we are driving in that will protect our sagittal cut, because the cut goes down as deep as this pin is and prevents any further infringement of the cortex or the cancellous bone. So at this point, we fix the tibial jig. And now we have a choice of either removing the entire assembly, but we prefer to just leave it there. It gives us a good sense of where we are. And once we've done that, we're now ready for our tibial resection. We check the depth of the guide. You want to make sure that it is a loose 4. So you can have what we call a loose 4 or a loose 5. The stylus should move pretty freely. You can see there's atromedial bone loss. You can also cross-check it yet again using an angel wing. And I think it's just a good way to make sure. So a little bit of time spent over here is really quite good. So this is a sagittal saw. We use a recip saw, and we use a retractor to protect the medial collateral ligament. And that's one thing which can inadvertently get cut. So using a Homan retractor, a small Homan, you can actually go all the way back. You don't have to worry about going on into the intercondylar notch, because you already have that screw which is going to be protecting your space. And once you've gone through, then all you need to do is to remove that medial wafer. And ideally, you want it to just pop out like we have done over here. And that is the edge. And you can see over here that screw has done its job. It's protected our sagittal cut from going deep. And at the same time, we've taken away about 4.5 millimeters of the medial tibial condyle. So you can measure this. 4.5 up to about 5 is good. Anything more than that, you've taken away too much of the bone. So here we're taking out roughly about 4 millimeters, 4.2 millimeters of the. So this is basically a measured resection technique. This implant lends itself to this option. At this stage, we remove our tibial assembly. Tibial cuts are done. And you can then take out the meniscus. We prefer to do it at this stage. Some people take it out right at the end. We prefer it in this stage because it's right there sitting right in front. And once you do that, it also decompresses your posterior condyle, and it allows your instrumentation to go in relatively easily. We are now established a tibial platform, which will be the guideline for the tibial, for the femoral resection. So the meniscus is out now, and we're pretty much done. At this stage, you want to make sure that you have a decent flexion gap, and you would insert a 8 millimeter insert. That's 8 and 9 millimeters. You want to make sure that the 8 goes in very, very easily. It should be a slip. The 9 is tight, and that's what you don't want. You want to make sure that the 8 millimeters should be, it should be a loose 8. A tight 9 is bad. And this is the spacer. You cross check it again. So you want to keep checking your gaps at every stage. Once you've done that, you use the resected tibial platform to guide your femoral cut. So this is an extension, and you take an 8 millimeter spacer because that's what we have shot for in the flexion gap. You convert that into the extension gap, and in extension, you pin the distal resection guide. And by doing that, you're getting a parallel cut to the resected tibial surface. And you then are in a position to remove the distal femoral condyle. You check your alignment at this stage. This allows you to check and to make sure that your overall limb alignment continues to be in varus. As I'm sure all of us know, that the principles of unicompartment is to undercorrect the deformity, leave the varus deformity in varus. By correcting it fully or overcorrecting it, you transfer the stresses to the lateral compartment and encourage early degenerative changes. So this looks pretty good. It's aligning to the first toe. So once you've done that, you're well aligned, and the next step is to resect the distal femur. Now you do this in extension, and as a small tip is tell one of your assistants to just flex it by about 5 degrees and give a little bit of a counter pressure, so that that allows for the for protection of the posterior structures. You again use a retractor, a Hohmann's retractor, that allows us to protect the medial collateral ligament and the anterior cruciate ligament. So you're between ligaments, and by going straight down, you one of the tips we learned is not going all the way through, and you leave the last couple of millimeters of the femoral condyle. It just helps us to be a little more selective in being able to protect the posterior surface of the femoral condyle. So at this stage, we can you can remove the guide and complete the resection of the femoral condyle, because you have done almost 90% of the resection, and it's just easy to just slip in your blade and complete the So again, you see we are taking out roughly about 4 millimeters of the distal femoral condyle. This patient So the indication here was osteonecrosis as opposed to osteoarthritis. So we did get a bit of a sclerosed bone. So once we've done that, we have done our extension gap because we removed the distal femur and the proximal tibia, and any osteophytes that are present are then removed. And the next step is to size the femur. So once the femur osteophytes are removed, you basically decompress the soft tissues. We then take the sizing guide, and again a couple of points wherein you want to make sure the two condyles are divergent. The medial and the lateral femoral condyles are divergent by about 18 degrees, but you want to make sure that your overall longitudinal alignment of your femoral component is at right angles to the tibial side, and you want about 2 millimeters from the top of the resection jig to the edge of the femoral condyle anteriorly. So you used various sizes until you get absolutely the right size, and you have about 2 millimeters of uncovered bone. It has a foot which goes into the posterior condyle, and you choose your different sizes so that you have about, that's what we're showing over here, a couple of millimeters of the surface of the at the top. So yet again, you can see over here that you got a couple of millimeters from the anterior surface of the guide to the anterior surface of the resected femur. So this is about the right size. This gives us good alignment. So we fix this this instrument. So again, we make sure that the overall alignment is at right angles. So yet again, I cannot overemphasize the need to be at right angles to the cut surface of the tibia. So you make your lug holes. And both these holes are directed upwards. So you want to make sure that these are very small instruments, and if you don't orient it well, you can actually inadvertently loosen or break the bone. So we use a curly-wurly again for our posterior condylar resection. Your distal cut is directed upwards, and this is the final cut, the chamfer cut. So once you've done that, all our cuts are done, and so we can now remove the jigs, remove the pieces of bone that you have that you've resected. If you've done your cuts right, they should all come out in little, one piece. That's the posterior cut. So you can see here we have protected the ACL, the MCL, and if there are any osteophytes medially, you can just remove those with the rongeur. So that's all our resection completed. You next need to size your tibia. Before that, what we're doing here is just checking our gaps, your flexion and extension gaps. So that's our extension gap. So he's still in varus. So this is what the overall alignment post-operatively will look like. You have no flexion contractures, and it's nice and loose. You want that gap about a couple of millimeters being able to wobble it. Again, the same trick, 8 millimeters being a little bit loose is really what you want. Tight unis fail very, very rapidly. They're very, very unforgiving, and patient complains of pain, and it causes changes in the contralateral compartment. So our surgery in terms of the bony resections are over. We now have to prepare the condyles. We now need to size the tibia, and this is the Persona system, which a single instrument gives you 3 options of sizes. So you can give, it has C, D, and E on the same. You can actually hook the edge of the instrument to the back of the tibia, and depending on which line corresponds to the anterior edge of the resected surface, you can get the appropriate sizes. So that hook actually goes right to the back, and you can pull it up and orient yourself quite adequately. The other way to do it, of course, is to measure it directly off the resected surface and to use your trial, and you can get an equally accurate idea. So we just prefer to do it this way because it's more anatomical. We just feel more confident being able to orient it well. One of the challenges with its predecessor was the option of the sizes, which were really quite poor. But with this system, we seem to get a much better coverage from anterior, posterior to medial lateral. So spending a bit of time around this is actually well worth the effort. So you can then bang it. It's got a bevel on the middle side. It's got 2 lug holes anteriorly. And again, both these lug holes are directed posteriorly. I think it's important to realize that, because the tendency is to go straight down. It doesn't work. And so it's the down and back orientation, as you can see over here very nicely. Both these holes are directed back. So once you've done that, your tibial preparation is done, your femoral preparation is done. We can now do the trial, and So that's the impactor and holder. You just whack it in. Uh, and this is the insert. You should be able to just slip it in. Like I said, you want that just loose, and you want a couple of millimeters laxity. So this is a tongue depressor, and this has a 2 and 3 millimeter side. And you can see here we are very easily able to put that in. 3 millimeters is a bit more of a struggle. It's tight, so that size is about right. This is really what gives you your orientation on in being able to choose the height or the thickness of the polyethylene. So it starts with 8 millimeters, which it really corresponds to about 4.5 millimeters of actual polyethylene thickness. So we spend a little bit of time over here to get that right orientation. And you can see over here we're still in varus. We're able to open that just a couple of millimeters, and that pretty much gives us our comfort level that we are in the right space. We are now ready for cementation, and one of the things we do is make very small. We use a 2.7 millimeter drill bit, make multiple drill holes, and I'll just sort of wrap it up. I know we're running short on time, and so I won't go all the way through till the closure because that's pretty standard. But I'd just like to show you a little bit of what we do to get cement out from the back. One of the challenges with the unis has always been getting the tibial and the femoral cementation out from the posterior side. And I actually picked this up from watching Dick Scott, who's been one of the masters of uni-compartment replacements. And what we do is we take a roller gauze and into the back of the tibia, and we just shove it in at the back, really sort of impact it at the back, because this, for one, it prevents any cement from going posteriorly, and any cement that does extrude is easily removed when we remove this packing. So we'll just see that part. So we pack it in, we push it in front of the medial collateral ligament. And again, your Z retractor protects both the gauze piece and your medial collateral ligament. This is the cementation. We put it on the bevel and on the lugs as well. So this is impacted in place. This is something that we use a lot of, the dental curate. It just helps us to get our cement at the back. Cement must come out from the back. There's no way that you want to leave any cement at the back. Otherwise, you might have to get in hold of one of your arthroscopy colleagues to try and pull out a retained fragment of cement. And this just very neatly allows you to pull out all of the cement. So this has brought out all the cement now. We just now need to impact our femoral component. That's a femoral component going in. Different way of doing it. We put our implant both in total knees and in unis. We put our cement on the implant, not on the bone directly. Can't say why I do that. I've always done it that way. It seems to work for me. So before anybody asks me the question, this is a disclaimer. We've always done it this way. And I don't have any arguments with people who do it the other way around or who do a hybrid form. So once we have done this, all that remains is give it a good wash. Um, and this is a vitamin E poly. And this has a dovetail configuration, so it just and again you want to make sure that it just sort of slips in. You shouldn't have to struggle with trying to push that polyethylene in, and this is a impactor. So that's the surgery. And at the end of this, you want to make sure again that your spacer 2 millimeters just sort of slips in, and you're able to extend it also. And you want to make sure that it's just sort of wobbling around and it's nice and easy. So with that, I'd like to thank the audience and thank the organizers for the opportunity. I'd be happy to take any questions if time permits you to do that. Thank you.